There's a line item buried in hospital bills across America right now that most Medicare recipients have paid without ever questioning it. It is not a copay. It is not your deductible. It is a charge that you were never supposed to be billed for in the first place. And according to a 2024 audit by the Office of Inspector General, the average overcharge for seniors who have been hospitalized in the past 3 years sits at approximately $14,000. Some people have paid far more. Some have paid less. But the pattern is consistent, widespread, and in most cases, completely recoverable if you know where to look and what to ask for. The charge I am talking about is called an observation status billing error. And it shows up when hospitals classify you as an outpatient under observation instead of admitting you as an inpatient, even when your medical situation clearly warranted full admission. That classification difference can cost you tens of thousands of dollars in the wrong charges for services Medicare should have covered entirely. I want to take the time today to explain exactly what observation status is, how hospitals use it incorrectly, why it costs you so much money when they do, and most importantly, how to audit your own hospital bills going back 3 years to find out if you were overcharged and how to file for reimbursement. Because in 2024, new guidance from CMS finally gave Medicare beneficiaries a clear pathway to challenge these charges retroactively. And at around the 11-minute mark, I'm going to walk you through a specific case where a 71-year-old heart patient recovered $18,000 in overcharges using the exact process I am about to teach you. This is Jordan Retires. If you are new here, welcome. This channel is about giving you clear, honest information about the financial rules that affect retirement in America, Medicare, billing, your rights as a senior, and the systems that are supposed to work for you but often work against you if you do not understand them. No jargon, no guesswork, just the facts you need to make better decisions and protect what you have worked your entire life to build. Hit the like button now and subscribe to Jordan Retires so you do not miss anything. And stay with me because what I am about to show you applies to any hospital stay you or a spouse have had since January 2021. If you spent even one night in a hospital during that time, you need to check your billing records. The numbers are going to make a lot of sense once I have laid the foundation. Let me start at the very beginning. When you go to a hospital as a Medicare patient, there are 2 ways the hospital can classify your stay: inpatient or observation. The classification determines who pays for what, and the difference in out-of-pocket costs to you can be staggering. If you're classified as an inpatient, you are formally admitted to the hospital. Medicare, Part A, your hospital insurance, kicks in. Medicare Part A covers your room, your meals, your nursing care, your medications, administered in the hospital, and all medically necessary services related to your condition. After you meet your Part A deductible, which into 2025 is $113. So Medicare covers the rest for the first 60 days. Your out-of-pocket responsibility is limited and predictable. If you are classified as under observation status, you are technically still an outpatient. You have not been admitted. You are being observed to determine if admission is necessary. Under observation, Medicare Part B applies instead of Part A. Part B covers 80% of outpatient services after you meet your Part B deductible, which in 2025 is $240. That sounds better at first, until you realize what Part B does not cover: your hospital bed, your meals, most of the nursing care, and critically, any medications the hospital gives you. Those medications are billed separately, often at hospital markup rates that can run hundreds or even thousands of dollars per dose. Here's where it gets worse. Observation status is supposed to be used for short-term evaluation, typically under 24 hours. The hospital is supposed to decide within that window whether you need to be admitted or whether you can be safely discharged. But in practice, hospitals have been placing Medicare patients under observation status for 2 days, 3 days, even 5 days or longer, billing them as outpatients the entire time, while those patients are sitting in a hospital bed, receiving exactly the same care as someone classified as an inpatient down the hall. The patient does not know the difference. They are in a hospital bed, they are getting tests, they are getting medications, they assume they have been admitted, they assume Medicare Part A is covering them, and then, weeks later, the bill arrives. And it is enormous. Now, here is the part that most people do not realize, and this is what makes this issue genuinely urgent. Until 2024, there was no clear pathway for Medicare beneficiaries to challenge observation status billing retroactively. You could appeal while you were in the hospital if you knew to ask, but once you were discharged, the decision was considered final. The billing stood. You were stuck with it. In March 2024, CMS issued new guidance in response to a federal lawsuit and years of advocacy from senior rights organizations. That guidance allows Medicare beneficiaries to request a retroactive review of observation status billing for any hospital stay going back 3 years from the date of the request. If the review finds that you should have been classified as an inpatient based on the medical criteria documented in your chart, the hospital is required to reclassify your stay, rebill Medicare Part A, and refund you the difference in what you were overcharged. That window is open right now, and it closes 3 years from the date of discharge. If you were hospitalized in January 2022, your window to request a review closes in January 2025. The clock is running. And most people have no idea this process even exists. Let me show you exactly what this looks like with a real example. This is the case I promised you at the 11-minute mark, and I want it to be completely concrete. Meet Robert. Robert is a 71-year-old retired electrician living in Tampa, Florida. In June 2023, he experienced severe chest pain and shortness of breath. His wife called 911. He was taken to a local hospital by ambulance. He spent 4 days in the hospital undergoing cardiac monitoring, stress tests, blood work, and medication adjustments. On day 4, the cardiologist cleared him to go home with a new medication regimen and a follow-up appointment. Robert assumed he had been admitted to the hospital. He was in a bed. He had an IV. Nurses checked on him every few hours. He had no reason to think otherwise. He received his Medicare summary notice 2 months later and saw that Medicare Part B had paid a portion of the bill, and he owed $11,400 in remaining charges. He called the hospital billing department, confused. They told him he had been under observation status, not admitted. They told him the charges were correct. They told him his medications alone accounted for $6,200 of the bill because those are billed separately under Part B. He asked why he was not admitted if he spent 4 days there. They told him that was a clinical decision made by his physician and that there was nothing they could do. Robert paid the bill in installments over 6 months because he did not know he had any other option. In early 2024, Robert's daughter saw a news segment about the new CMS guidance allowing retroactive observation status reviews. She contacted Jordan Retires. We walked her through the process step by step. Here is what actually happened when Robert requested a retroactive review. Robert's daughter submitted a formal request to the hospital's Quality Improvement Organization, or QIO, which in Florida is KEPRO. She included Robert's discharge summary, his medical records from the stay, and a written statement explaining that he had been under continuous care for 4 days with cardiac monitoring, which meets the CMS criteria for inpatient admission. KEPRO reviewed the case within 30 days. They determined that, based on the clinical documentation, Robert's condition and the intensity of services provided met the definition of inpatient care under the Medicare 2-midnight rule. That rule, established by CMS in 2013, states that if a physician expects a patient to need hospital care spanning at least 2 midnights, the patient should generally be classified as an inpatient. Robert's stay spanned 4 midnights. The documentation supported inpatient status. KEPRO issued a determination in Robert's favor. The hospital was required to reclassify his stay as inpatient, rebill Medicare Part A, and refund Robert the difference in what they were overcharged. Here is the financial breakdown. Under observation status with Part B, Robert's total out-of-pocket costs were $11,400. Under inpatient status with Part A, Robert's total out-of-pocket cost would have been his Part A deductible of $1,932, which he had already met earlier in the year from a different hospitalization. His actual out-of-pocket cost under the correct classification should have been $0. The hospital refunded Robert $11,400. But the story does not end there. Robert's medications during that stay, which had been billed separately under Part B at hospital markup, were now covered under Part A as part of inpatient care. Medicare reprocessed those claims. Robert received an additional refund of $6,800 from the pharmacy billing. Robert's total recovery, $18,200. That money was sitting in incorrect billing for over a year. He had already paid it. He thought it was gone. And the only reason he got it back was because his daughter knew to ask for a retroactive review. Now, I want to address something directly because there is context around this issue that makes it especially urgent right now in 2025. The March 2024 CMS guidance I mentioned was not a voluntary policy update. It was the result of a class action lawsuit filed in 2022 by the Center for Medicare Advocacy on behalf of thousands of Medicare beneficiaries who had been improperly placed under observation status. The lawsuit argued that hospitals were using observation status not as a legitimate clinical tool, but as a financial strategy to shift costs from Medicare to patients. The evidence was damning. Internal hospital emails obtained during discovery showed that some hospital systems had set quotas for observation status to reduce their Medicare Part A utilization, which affects their reimbursement rates from CMS. In plain language, hospitals were financially incentivized to keep you classified as an outpatient under observation, even when your medical situation clearly warranted inpatient admission. CMS settled the lawsuit in early 2024 and issued the new guidance as part of that settlement. That guidance is now policy. but it is not automatic. It does not apply to your billing unless you request the review. Hospitals are not required to notify you that you have the right to request a retroactive review. You have to know to ask for it. Here is where the timeline gets critical. The 3-year window I mentioned earlier is not 3 years from today. It is 3 years from the date of your discharge. If you were discharged from the hospital on February 10th, 2022, your deadline to file a retroactive review request is February 10th, 2025. After that, the billing becomes final and you lose your right to challenge it. We are now in late 2024, moving into 2025. That means anyone who was hospitalized in 2022 is approaching their deadline. If you had a hospital stay in 2022 and you were billed under observation status, you have weeks or at most a few months left to act. The second reason this is urgent right now is because of recent changes to the 2 midnight rule that took effect in January 2024. CMS clarified that the 2 midnight rule applies not just to the expectation of care at the time of admission, but to the actual care provided. That means if you were initially placed under observation for what was expected to be a short stay, but your condition required care that extended beyond 2 midnights, the hospital is required to reclassify you as an inpatient retroactively during your stay. Many hospitals are not doing this. They are keeping patients under observation status for the entire stay, even when the care provided clearly crossed the 2 midnight threshold. That is a violation of CMS policy, and it is exactly the kind of case that a retroactive review is designed to catch. Now, let me talk about how you can check your own hospital bills, because this is the most practical step in this entire video. The first thing you need to do is gather your hospital discharge paperwork from any hospital stay you have had in the past 3 years. Look for a document called a discharge summary or a hospital billing summary. This document should include your admission date, your discharge date, and critically, your patient status. It will say either admitted or observation. If you do not have this paperwork, call the hospital's medical records department and request a copy of your discharge summary. Under HIPAA, they are required to provide it to you. Most hospitals charge a small fee, typically $10 to $25 for copying medical records. Pay it. You need this document. The second thing you need is your Medicare Summary Notice, or MSN. This is the statement Medicare sends you every 3 months, showing what services you received, what Medicare paid, and what you owe. Your MSN will show whether your hospital stay was billed under Part A or Part B. If it was billed under Part B and you spent more than 1 night in the hospital, that is a red flag. You were likely classified under observation status. You can access your MSN online through your Medicare.gov account. Log in, go to My Claims, and filter by date. Find the hospital stay in question. And look at the billing code. If you see codes in the 99219 to 99220 range, those are observation status codes. If you see codes in the 99221 to 99239 range, those are inpatient admission codes. The third thing you need to know is the 2 midnight rule criteria. According to CMS, you should generally be classified as an inpatient if your physician expects you to need hospital care that spans at least 2 midnights, based on factors like the severity of your condition, the intensity of services you require, and your medical history. Here is what qualifies for inpatient status under CMS guidelines: continuous monitoring for a life-threatening condition, intravenous medications administered over multiple days, post-surgical recovery requiring more than 24 hours of care, diagnostic testing that requires hospital-level observation over multiple days, or any condition where a physician documents that outpatient care is not medically appropriate. Here is what does not automatically qualify you for inpatient status: emergency room treatment, followed by discharge the same day, diagnostic testing that can be completed in a single day, procedures performed on an outpatient basis even if they require a brief recovery period, or stays under 24 hours where the physician documents that outpatient observation was medically appropriate. The line is not always clear, and that is exactly why the review process exists. If you are uncertain, you should request the review and let the Quality Improvement Organization make the determination based on your medical records. Now, here's a nuance that catches people out. If you were hospitalized and then transferred to a skilled nursing facility for rehabilitation, your observation status classification affects more than just your hospital bill. Medicare only covers skilled nursing facility care if you were admitted as an inpatient for at least 3 consecutive days before the transfer. If you were under observation status, those days do not count toward the 3-day requirement. That means you could be stuck paying out of pocket for nursing facility care that Medicare should have covered, often costing $8,000 to $15,000 per month. If this happened to you, the retroactive review can reclassify your hospital stay, meet the 3-day inpatient requirement, and trigger Medicare coverage for the nursing facility stay retroactively. The financial impact of getting this right can easily exceed $30,000 or $40,000 in some cases. Let me give you the action steps clearly. The first and most important thing you can do today is request your discharge summary and your Medicare summary notice for any hospital stay in the past 3 years. Write down your admission date, discharge date, patient status, and total days in the hospital. That information is the foundation for everything else. The second step is to identify your Quality Improvement Organization, or QIO. Every state has one. These are independent organizations contracted by Medicare to review hospital care quality issues, including observation status disputes. You can find your state's QIO by calling 1-800-MEDICARE, that is 1-800-633-4227, or by visiting medicare.gov and searching QIO directory. The third step is to submit a written request for a retroactive observation status review to your QIO. Your request should include your name, your Medicare number, the name of the hospital, your admission and discharge dates, a copy of your discharge summary, a copy of your Medicare summary notice showing Part B billing, and a brief written statement explaining why you believe you should have been classified as an inpatient. You do not need a lawyer to do this. You do not need to hire a medical billing advocate, although they can help if you want professional assistance. The process is designed to be accessible to Medicare beneficiaries directly. The fourth step is to follow up. QIOs are required to acknowledge your request within 10 business days and to issue a determination within 30 days of receiving all necessary documentation. If you do not hear back within that time frame, call them. Be polite, but be persistent. The fifth step applies if the QIO rules in your favor. The hospital will rebill Medicare and issue you a refund. That refund can take 60 to 90 days to process. If you do not receive it within 90 days, contact the hospital's billing department and reference the QIO determination number. If they do not cooperate, contact your QIO again. They have enforcement authority. The sixth step is strategic. If you had multiple hospital stays in the past 3 years, check all of them. Do not assume that if one stay was billed correctly, the others were too. Each stay is independent. Each one should be reviewed on its own merits. Let me come back to Robert, the retired electrician from Tampa, whose daughter reached out to Jordan Retires after seeing the news segment about retroactive reviews. Robert came back to us 6 months after he received his refund. He told us that the $18,200 he recovered was not just money, it was validation. For over a year, he had felt taken advantage of by a system he had trusted. He had paid into Medicare for 45 years. He thought it was supposed to protect him. Instead, he got a bill that wiped out a significant portion of his emergency savings, and when he questioned it, he was told there was nothing he could do. Getting that money back meant he could rebuild his emergency fund. It meant he and his wife could stop worrying about how they were going to cover the next unexpected medical expense. But more than that, it restored his confidence that he was not powerless in dealing with these systems. Robert now checks every hospital bill he receives. He asks the admitting physician directly whether he is being admitted as an inpatient or placed under observation. And he has shared his story with 3 friends from his union who had similar experiences and did not know they could fight back. That is not a financial benefit I can put a dollar figure on, but it is real. And the retroactive review process is what made it possible. If this video gave you something useful, please share it. Share it with anyone you know who has been hospitalized in the past 3 years. Share it with a family member who handles finances for an aging parent. Share it with your church group, your book club, your neighbors. This information has a 3-year expiration date for every hospital stay, and most people do not know it exists. Drop a comment below and tell me whether you have ever been billed under observation status. Tell me whether you knew the difference between observation and inpatient before watching this video. And tell me what topics you want Jordan Retires to cover next. Every comment gets read, and every story from this community shapes what comes next on this channel. If you found value here, hit that subscribe button. This is the kind of information that saves people real money, but only if it reaches them in time.